This is part 2 of Nerve Block Talks with Arun Nagdev out in California, the Nerve Block Master. In this podcast, we're going to talk about 3 different blocks, or 3 different, procedures. The first one is arthrocentesis. It's so important for us to do this. It's easy with ultrasound, and we'll discuss a few nuances about that. Then we're going to move on to a block that looks pretty easy. I haven't done a whole lot of these in my career thus far, but I'm telling you, I'm going to start doing it a little bit more. It's the dorsal penile nerve block. Now, what's interesting about this is you don't want to do it like right on the penis, because I think that's what I thought about it at first. Dr. Nagdev recommends going a little more proximal on the mons to actually inject there so you have more space. And lastly, we're going to talk about the classic interscalene block. Check it out.
So something I always teach my residents is when you're evaluating cellulitis, you always pop a probe on for, if it's an abscess. And sometimes you can actually really see underneath and look at the joint space. And I always call it the joint capsule, not really the joint space, because you're looking at the swelling of the joint space, which extends the capsule. Here you see the tibia coming down.
Yep.
And then there's the talus. We're in this position right at the point for the tibia and talus. Orientation doesn't matter to me as long as you're comfortable recognizing which is up and which is down. So I don't really care how you pick that up. You can see here, the left has no effusion. This is just adipose tissue here. And this, the joint capsule, is swollen with something. Can it be infectious, inflammatory? I don't know. This is a patient my intern sees by himself, like 10:30 at night, right when everybody's got home. He comes up and he's like, "Hey, we're gonna have this guy with cellulitis of the ankle. I want to give some antibiotics." And he's like, "Can you give me some help?" He's not blowing it off, but he's like, "I think it just hurts. Let's go look at it together." So he pops the probe on, and again, you can see clear. Here's the tibia. This is the other way. So it's actually nice, just as long as you have your convention tibia, and this is the talus. And this is capsule effusion, which is pretty obvious. I think this didn't take much cognitive load to figure out. I'm going to see if the next one plays as well. You can see it here. You can see it here.
Yeah.
Kind of fanning through it. Here's his other ankle, which is always the best, right? You always want to use the other ankle as your landmark.
Yeah.
And here you see that V, the tibia talus, and this is just probably fat and just supported structure. So really nothing in this space. I'm going to see. I think he comes in.
That's intense. Arun, before I'm curious, like you see that effusion, and I've seen a couple of ankles, like not a whole lot of ankles, but a couple of ankles. The border around the capsule, it's pretty irregular, right? Like it's not like a normal kind of joint effusion that I'm used to seeing. I mean, it's not like I see a bunch of effusions. Does that mean anything? Does that mean it's more likely to be inflammatory, or is it just like a finding that you see sometimes?
Yeah, I don't know the answer to that, Dick, but I think this is the same path. There's a nice paper in, I think, Academic Emergency Medicine that answers kind of what you're getting at. Can you differentiate it without sticking a needle in it? I think curious, if you see an effusion and the patient has any symptomatology that would lead you to believe there could be an infection, I think you just stick a needle in it. It's such a simple procedure.
Yeah.
And I think that it's the analogy of lumbar punctures, right? Nobody's like, well, a guy's febrile and he's altered.
Yeah.
I think it's probably low likelihood. I'm going to let him slide. I mean, I think that you the patient, right? You will go through all means to get it done. I think this is a joint defying injury, right? That could be really catastrophic. This gentleman had a gonococcal infection in his ankle, which you don't see very often anymore.
Right.
But again, this is a nice pickup by our intern, who then I think proceeded to tap him. And I'll show you the technique for the tap. It's an out of plane technique. This is the one of the few times I do an out of plane technique. What's nice about the out of plane technique is you don't need as much space. Let me find it. And so for me, this is kind of a simple procedure, because what I do is I cover that anterior tibialis with my tendon. I give a little, you can do a skin wheel. Sometimes I'll do ethyl chloride spray, keep yourself sterile. And I come in at almost 90 degrees, making sure I'm not going to go through the tendon, because you puncture that tendon, they're going to probably kick you in the head.
Yeah, those hurt.
A little bit off, and then almost a 90-degree angle, and you pop in. again, this is like the central line. You're not going to see the needle tip, and you're not going to follow the needle. You're going to maybe see the tip at the bottom. And sometimes I'll just touch the talus and aspirate. And we've had a few of these where this is, I think, the third one that's gone to the OR because of a joint infection. And these are easily missed because we all see a red hot swollen area and we assume it's a cellulitis or an abscess, and we forget that these joints underneath can be infected. The one question everybody asks me on this is, what if the skin overlying it is red and hot? Are you scared to dump anesthetic, to put bacteria inside of it? All the orthopedic surgeons I've spoken to feel that if you find a joint effusion and you really believe it's a joint infection, you should just go ahead and tap it. If you can find a spot where there's no infection, where there's no cellulitic skin, great. But if you can't, then the right thing to do is talk to them and stick a needle in it.
Sure. Yeah, no, that makes sense. Now, I have a question for you. So you taught me in the last one about going out of plane for knee taps. Not out of plane. The probe is, so when I'm usually diagnosing knee effusions, I usually start with the probe marker, going up, right, to kind of like identify landmarks a little easier. But then you taught me about turning the probe perpendicular to the plane of the leg and then coming in lateral with your needle. So you're in plane, but you're like transverse to the angle of the knee. Exactly.
Right.
Can you do something like that with the ankle as well? I realize it's a little more of a curved structure, so you might like have some dropout, but have you ever done it that way?
I've never done. I think you need a really short, small probe. I think it just adds a little level of complexity. And this is pretty easy because you're just going bank aspirate. I mean, it's literally, that's the entire procedure. And the intern did this aspiration himself. I mean, obviously I held the probe.
Sure.
I sprayed the ethyl chloride. It was sterile, and he got sterile and went pop, pop. And it was a pretty simple aspiration. The other tip I always tell my residents when they're tapping joints is whenever they pull anything out of a joint, we have Epic to take a picture of it and put it in the chart. And the reason is this one specifically was so purulent that laboratory couldn't run the white blood cells.
Because they were just all white blood cells?
It was all white blood cells. It was just too purulent. And so I think whenever you aspirate a joint, you should always take a picture of it and dump in the chart. Your orthopod will really love you for it.
Yeah, that's a great idea. It's a great idea. So is there any joint you don't tap? I mean, obviously prosthetic joints are like we're at our shop, like we ask our orthopods, but I mean, you can do this to any joint, right?
Any joint. I mean, I'm not a big, huge fan of doing like distal toes and fingers. I think no orthopedist is going to feel like you have a toe infection. It's almost always gouty. So that can be up to you. But I think that when you identify fluid, I mean, you can use common sense as a clinician, say this is clearly arthritic. You've come in here 14 times in the Smith and you have arthritic pain. You're walking on it, you're bending it, but it hurts, and you're not febrile, you're not warm, you're not, on immunosuppressives. Sure. But otherwise, I think if you see a joint effusion and it's part of your differential, I think you just stick a needle in it.
Brilliant. No, that makes sense. And I agree with you. I was just curious because I don't know. There seems to be a little bit of a reluctance to do like these joint aspirations. And I feel like with the landmark, I could understand the reluctance to do it. But if you see the ultrasound or you have it, it always seems so simple, right? I mean, it's not like an IV or even a nerve where you're trying to get to like a specific area. It's like you have a collection of fluid, you stick the needle to it a little bit. You can be a little off center and you'll still get that fluid out. So I was just curious what your thoughts were, because I do them every chance that I get, to be honest.
Yeah, but joint fusions I love. There's a famous paper out of, I think it was joint disease. There was a study where they had cadaver-based models, and they had I'm the shoulder orthopod guy or girl, I don't remember, who was a senior person who did joint injections and joint aspiration. And then they had an orthopedic fellow who hadn't done anything other than a few blind ones. And they compared them with dye injection with ultrasound versus ultrasound for the fellow and non-ultrasound for the expert. The expert was into the joint 70% of the time versus the non-expert was into the joint, I think it was 99.2%, whatever the number was. It goes to show you and we had a case about 4 years ago where one of our physicians had a gentleman injection drug user wasn't able to move his shoulder, and he tried, couldn't get fluid. Orthopedics came in, they tried, they had no source of infection, they did endocarditis workup, they had on the floor. The orthopedic attending called me and said, can you go upstairs? And we went upstairs in one pass with the intern, was able to get pus out. And it was
Oh my gosh.
And this happens in the center, right? I mean, people are injecting joints the same way. If you're going to inject steroids into a joint or pain control for chronic pain, you got to use ultrasound.
Of course. Yeah. I don't know. And that's another thing, discussion about, like central lines, for instance. Like I remember when I was I think I was an intern, and one of my attendings, who was like, a younger dude, and I was, whatever, he made me do a blind IJ. And I felt like I was like, he had asked me to steal from a store or something. Like I was doing something that I knew morally was horrible. But the idea was, well, what if you don't have an ultrasound? I don't know, like, there's always going to be an ultrasound. Why not do the thing that is like better?
Yeah, exactly. Would you do that to your mom if he was? No. So it's like, it's that whole, if you don't have an ultrasound, if there's no electricity, if the world blows up, what are you going to do? You're like, well, I won't be practicing emergency medicine. I'll be floating somewhere in particle matter. Right?
That's why I ride my bike everywhere, just in case. I'm practicing. That was all things arthrocentesis of the ankle. Now let's talk about the dorsal penis block. I see it.
Yeah,
I see it. Looks like a funny face.
It looks like a funny face, right? So this is a cross section of the penis. Really, as you know from years of emergency medicine, just don't hit this. This is where you urinate from. This is all a gold mine of blood to aspirate. And what's interesting is you can see up here, the nerves, the dorsal nerves run under buccal fascia. And you're like, how are we going to put a probe on somebody's penis? Because I remember doing this with one of my fellows moonlights at a center of priapism excellence, because it's in a part of San Francisco where a lot of people inject a lot of things into their penis for recreational purposes.
Yeah, bummer.
Yeah, so he does this twice a shift sometimes.
Wow.
And he's like, how do you put the probe on a penis? I'm like, well, you don't put it. You put it higher up on the mons.
Oh, okay.
Flat, right? And so I'm going to show you the image. And the nice thing about this is the goal is to get underneath the buccal fascia and then inject. Fluid will track in the space. I do it on both sides in this video. Okay. You can theoretically, and he did it on one side and said it worked fine. I did it on a guy there's a few weeks back, and it was such a dense block. The urologists were like, how did you do that? It's so impressive. Really? So I'll show you the video, and you'll see how it's not that hard. These are going to be short clips, but you can see here, this is, again,
I see it. It's the corpus.
The spongiosum.
Yeah.
The cavernosus is me down here. I'm proximal, so I'm really high up.
Okay.
And again, what you're looking for, see how this is vasculature. Let me see if it compresses.
Okay, I see that.
Right. So now the goal is really just to get underneath this plane and go here. Even if you go into the spongiosum, who cares? You'll see the video. I let one of our mid-level providers do this. Linear probe in plain view. You'll see, again, compression, just to make sure you guys all know where we are. Let's see. Okay. So the needle comes in. She comes in a little bit closer than I like. I would allow her to come laterally.
I see.
But she'll come right here. You'll see.
Now, are you holding the probe here, or is she holding the probe?
She's holding the probe and holding the needle. This is just a 5 cc injection. See there, she's injecting. Again, I would like her to come back. I'll do it on the other side, and I'll come a little bit more lateral.
I see.
You see where she is? So she goes into which is fine. It's okay because you're going to go in there anyway, right?
Yeah.
And then just injects and opens the space up. You see that? I'll come onto the other side and do the same thing, I think. There you go.
Yeah, that looks great.
So it's a really easy block to do. And then after showing this to my fellows on video review, they were like, okay, and literally had 2 cases. You see all the edema here already, correct?
Yeah.
I'm going to come to the other side. The other side might be cleaner. Again, you can see the edema here.
The appropriate edema due to what you just injected, right?
Correct.
Yeah.
So I'm coming a little more lateral, and I'll come in a little bit flatter. I'll just pop underneath buccal fascia. And then I'm just going to inject, and you're done. So you're far away from anything that's worrisome. Like, I don't want to hit any vasculature here. The nerve is right here. And now I'm just going to inject and fill this space up. And you'll see it kind of fill up with anesthetic right there. And I'm pretty much done. And that block, now you have a dense penile nerve block. You let them sit 15, 20 minutes, and you have an easy confirmatory pathway, because I think the failure of the block is like when I failed a femoral nerve block, I go above the fascia iliaca. This is just underneath buccal fascia.
I see. So with this block, are you doing like 5 total, or are you doing like 5 on each side? Like, what's your normal volume?
I do 5 on each side. Okay. And I think you can only, I think if somebody may knows better, I think you can do it on one side because it's going to track over.
Just tracks over.
I just did both sides because it's not hard to do. Yeah. And if somebody's going to stick a large 18 gauge needle into my penis, I want to make sure that there's enough anesthesia and saving $8 for the hospital on bupivacaine.
Yeah, right.
Isn't my most important action item.
Yeah. No, that makes perfect sense. And also, like, I don't know, like, it seems like, and I could be wrong, but it seems like you could probably treat these pretty similarly, maybe, to like something distal, like a ulnar nerve block. Would you do this as far as like needing to put them on a monitor? And of course, this is all like the right way to do nerve blocks is always put them on a monitor, make sure you're doing all this stuff. But if you're just using 5 to 10 cc's of lidocaine, something kind of distal, easily away from, large blood supply, you probably be safe to do this. Because I'm just trying to think, we're so crowded, and sometimes we don't have the ability to put all these patients on monitoring.
Well, it's a great point, and I think this is a discussion we're actually putting together some documents for ACEP on this, and this is a kind of a question we've gone back and forth on. Some people think anything in the abdomen, chest, pelvis should be on a monitor. Some people think under 10 cc's is probably not need to be on a monitor, like a forearm nerve block.
Sure.
I think if you want to just play it safe, you can put them on just a pulse oximeter and see if they have any tachycardias.
Sure.
And just be a nice way to monitor them. I do believe that if you want to be a purist, I would just put everybody on a monitor.
So for these kind of blocks, this is another thing we talked about last time, as far as like that a blunt tip needle is probably the best way to go. With these very superficial blocks, are you still using that blunt tip needle as kind of like a general rule?
Yeah, I think the right answer, Jacob, is to always worry about peripheral nerve injury. So if you can, and if it's possible, the short spinal block needle, the spinal needle is the kind for pediatric LPs, the 21 gauge is really the ideal needle for this procedure. You want to break the skin and then slide that underneath. It's a little bit more blunt. So theoretically, it would have a little bit less chance for some type of contact with the nerve. That would be our recommendation. Does it happen? I think every time in every ER, I don't know if that's true or not.
No, reasonable. That makes sense. This dorsal penis block seems like such a good idea. I mean, I've had patients wait for way too many hours with priapism because I didn't want to come in because the procedure to drain that blood is so painful. You do it this way, you have a much higher chance of success. The last thing we're going to talk about today is the interscalene block. Check it out.
Not the best visualization. The vasculature is here.
Okay.
Maybe here. I can't tell. But this was a patient, you could see kind of the middle scalene, not classic, not classic, but this is that brachial plexus right here.
I see it.
And some people will say C5, C6. That's probably not true. It's probably C5 right here, C6. Anesthesiologists commonly like to go into the plexus and inject. I don't like to do that. I like to go periplexus. So my goal is to get fluid that tracks down the middle scalene and gives analgesia here, or gives anesthetic there. So you see she's coming in really laterally, which is fine.
Yeah.
And she's trying to get underneath this fascial plane. This is the prevertebral fascia.
Okay.
She achieves that. She'll closer than I like to C5.
Okay.
And then hopefully starts depositing anesthetic. There she goes. And you can see the fluid. Not yet. She's still in the muscle.
So are you doing this like you are pushing the anesthetic?
Yeah.
Okay.
So I'm always pushing normal saline first to open the space. I never push anesthetic first. I always push normal saline.
Okay.
And then she's there. She's starting to maybe inject. Whenever I see fluid going backwards, that means you're in the muscle. When I see fluid tracking down, that means I'm in the fascial plane. And you
Okay.
should see this. There it goes. She's starting to open that space up.
Nice.
And again, I would like her to be a little bit farther away, but she had a hard time opening that space up, which happens. But she's being very cautious,
Which is good.
which is very good, and not going interplexus. If you go in between this plexus, the block works faster. Outside the plexus, the block works slower, which I'm okay with.
Yeah, of course. I like that.
And then just kind of, now you can see, it's tracking down because now you can see this so much clearer. There's probably the arteries over here.
There it is.
And let's see if we can follow this plexus around. There you go. You see that? That's all air that she deposited.
Yep.
Right here is a really nice image at the end she gets to. So you can see this is kind of the brachial plexus coming down, the supraclavicular, and then there's all the air that she dropped in there.
Now, I have a question for you. Now, this is something that I haven't done a whole lot, but a friend of mine, Justin Cook, who does a bunch of like procedures, he works out in Portland.
Justin's one of my residents.
Oh, that's great. Actually, I didn't know that for some reason. But yeah, of course, everybody that does good at procedures has worked around you at some point.
Justin's amazing. He's better than me at anything you do. He really is.
He's a really good drummer. I don't know if you drum or not. But
Justin, if I'm even half as good as a clinician as Justin, I'm a lucky person. Really, seriously, he's such a badass.
I love the guy. But what he was teaching me is, he comes in. So let's say like, here's the bevel. He comes in, and if he's having trouble getting it through, he will twist it to try and like kind of cut in without advancing it further.
Yeah.
And he says that works. And I've done it a couple of times with tricky IVs. If I'm having trouble with like the anterior part tenting too much, I'll kind of place, like, here's the IV. I'll place the needle here and then just twist it until I see it kind of pop through. Do you ever do that with fascial planes?
That's a great idea. That's something I'm going to try. I like that idea. I'm going to steal it. Thanks, Justin. That's a great idea.
Classic Justin. I mean, teaching us all new things. All right. That's perfect. Thanks so much for talking to us about these 3 blocks. And I can't wait till next time.
Later, Jacob.
See you, buddy. Thanks so much. Always such a great time sitting down with Arun and talking about procedures, specifically nerve blocks and arthrocentesis. We are very much looking forward to hearing your experience. If you want to learn a little bit more about nerve blocks, check out Arun Nagdev's website. That's highlandultrasound.com. It's a website that I frequently refer to whenever I have questions. You can also reach out on Twitter at Nagdev Arun or at Core Ultrasound. Hope to hear from you soon, and happy scanning.